and you can continue chatting. Dr. Weissman, would you prefer questions during or after?
During is fine. I think that's more natural, and if we're just doing the didactic, that'll work out well.
Okay, perfect.
And I'll try. Are you going to drive for me?
I can, certainly.
Okay, that would be great. Okay, so I'm going to be speaking today about unconventional natural gas production and lung health. And this is the same presentation I gave just a couple months ago for the University of New Mexico ECHO. So I apologize if anybody saw that. And we'll go to the next slide. And so I have no commercial conflicts of interest to disclose. Next slide. So the objectives here are to learn about recent trends in using natural gas and unconventional natural gas production, to provide an overview of unconventional natural gas production process and associated respiratory hazards, and to familiarize participants with requirements of OSHA's respirable crystalline silica rule that are relevant to unconventional natural gas production. Next slide. So we'll start with this first item. Next slide. So this graph shows trends in energy consumption in the US over the years. And as you can see, since about 1950, there's been a marked increase in per capita or in energy consumption in the US. And if you look at the types of sources of energy, and this includes electrical generation, this includes transportation, this includes heating. You can see petroleum is our biggest source of energy. You can see in the blue line there, you can see natural gas in the last couple of years has gone up, and in parallel, coal has gone down in black. And then at the bottom, you see in red nuclear, and then renewables are quite a bit lower. So you can see this trend in overall energy consumption. Natural gas in recent years has gone up quite a bit at the expense of coal, which has gone down. Next slide. And if you look just at US electrical power generation, and this graph shows 2005 to 2019, you can see on the top, you can see for blue all fuels, and you can see it's cyclical because different times of year you have different amounts of energy generated. Then if you go down to the group of lines that are down below, you can see the brown line there is coal. And you can see the brown line has trended down as the green line has trended up. So coal, again, going down for electrical generation, and natural gas going up. You can see yellow nuclear, which has stayed about the same, and renewables are quite a bit lower. Next slide. So where's all that increased natural gas come from? And really it's come from a dry shale production. It's come from unconventional natural gas production, what people call fracking. And so you can see total natural gas production in that blue line at the top going up, up, up. And you can see in the colored segments at the bottom right side of the graph of the sources, the formations, where the shale oil is coming from. So really unconventional natural gas production has really accounted for this rise in natural gas and this fall in use of coal. Next slide. This slide shows where unconventional natural gas production is happening. Again, people call it fracking, but as we'll show you in a couple of slides, hydraulic fracturing is only part of the process. But you can see over on the right, in our part of the country, we're a major site of production. Then you can see, Texas and Oklahoma and a bit of New Mexico, the Mountain West, and even a little bit out in California. Next slide. So this schematic shows a little bit about how the process works. And as you can see, there's a lot of trucking of materials that are involved in unconventional natural gas production. And one thing that's unique is if you look at this well, where it says well injection, if you follow the well down, you see how it goes down and it turns 90 degrees. Well, that's one of the key new aspects of this natural gas production. Instead of it being a conventional like oil or gas well from the past that was straight up and down, what we have now is horizontal drilling. So what you do is you drill down to the strata where you need to be, and we now have the ability to turn and drill horizontally into the strata. And then what's done is a slurry of water and sand and chemicals are injected into the well. And you can see over at the bottom right where it says induced fractures, you go ahead and you put fluid down there under pressure. You fracture the strata. The fracturing of the strata, it's called hydraulic fracturing. You put the fluid down, you fracture the strata, and then that allows the extraction of natural gas and also the wet gas, the oily stuff. And after the fractures are induced, a slurry that includes what's called proppant, which is a sort of a solid material that's used to hold the fractures open, is instilled in. So basically a slurry typically of sand and water is put in that holds the fractures open. Then after that drilling and fracturing and injection of proppant, then you can get flow back. You can return material out, and you begin harvesting natural gas, dry and wet gas. And when you remove that stuff, you produce sort of contaminated water when you pull it back, because it has the materials from the natural gas and it has chemicals in it. And that needs to be treated. And you can see that up on the upper part of the figure on the right. Next slide. And so here's a schematic that shows the materials used to perform hydraulic fracturing. And as you can see, water and sand make up about 99.5% of what's put into the well. And in a typical well, it's really a huge amount of material. If you look over to the far left, between 11 million and 26 million liters of water per well, between 1.2 million and 2.9 million kilograms of sand. So really quite a bit of material. And then in addition, that little slice from the pie that you see extended out to the right, you can see the various chemical agents that are put in. So surfactants and pH adjusting agents and corrosion inhibitors and biocides and friction reducers. So, and these are often proprietary and unclear exactly what chemicals are added to the slurry. Next slide. So here's a picture from above of an unconventional natural gas production site. And you can see up at the upper right-hand side, you can see the multiple trucks that are carrying sand. You can see those boxy, kind of yellowish-looking gold things. Those are sand movers. You can see all the trucks with tanks, with water. So these sites are loaded with vehicles. So these aren't really, these aren't like a fixed construction site typically. Typically, these are much more mobile in terms of the equipment that's there. And so in addition to whatever you get from the well, you get in the air the emissions that come from the diesel engines and that sort of thing. Next slide. So here are some of the things that you can see that are in the air, that are air pollutants, if you will, that people can be exposed to. You can see, of course, in the upper panel here, you can see that there are gases. So you get the natural gases that are associated with the gas, methane, ethane. You can get carbon dioxide, hydrogen sulfide, nitrogen, helium, trace elements. In certain parts of the country, there have been concerns that if you're in areas that have a lot of radon gas, you could potentially get some radon gas, some radiation out of it. Down below in the lower panel, you can see hazards by type of operation. So where are you at in the process in terms of pad construction and drilling, and stimulation, fracturing, pulling stuff out. So you can get silica as an exposure in that first column. Silica, you are using massive amounts of sand in these wells, and sand is silicon dioxide. And when that sand is moved, it can be fractured and create respirable sized particles. You can get diesel particulate material, the next column. You saw the trucks, so DPMs. You get volatile organic carbons, VOCs, volatile organic hydrocarbons, I'm sorry. You can DTECs, which are the various organics that are associated with the gas. Again, hydrogen sulfide, KHs, and you can read across. Those are the various inhalational hazards that can be present. Next slide. So next we'll talk a little bit specifically about one of the airborne hazards, which is crystalline silica. Next slide. So here's a picture where you can see the sand transport to the hydraulic fracturing site. And you saw from above that earlier picture, the sand delivery truck. So if you look at the left panel, you can see the sand delivery truck. And the sand delivery truck moves, the sand is moved by a device called a sand mover, that blue vehicle with the fence above it. And it uses air to move the sand over to what's called the dragon's tail, which is on the right side. So this site over here, there's a blender. The sand comes to a blender. It's mixed with water, and then it goes into the well. And you can see, popping back over to the left-hand picture again of the sand mover, you can see the clouds of dust that are coming off the top of it. Because again, this is being moved with air. Next slide. And so as you can imagine, people that are standing on top of these sand movers can potentially have substantial exposures. So you see that worker on the left standing there in the clouds of dust. Over on the right, you can see the dust emanating from thief hatches. Thief hatches are hatches in the top of the sand mover where you can look down and make sure that everything is operating appropriately. Next slide. And so when NIOSH did sampling back a couple of years ago to look at personal breathing zone respirable crystalline silica for different kinds of operations, you can see that people, for example, if you look at a couple of the bars over on the right-hand side, sand mover operators, T-belt operators, the people that are involved in moving the sand can have quite substantial exposures. And out of 111 samples altogether collected at the time, 68.5% exceeded the NIOSH recommended exposure limit for respirable crystalline silica, which is 0.05 milligrams per meter cubed. Next slide. So one of the things that NIOSH worked on was developing engineering controls to limit exposures. So this is a device called a mini bag house, which basically these are bags that are placed over the thief hatches that catch the dust and particles can drop back in. Now, one problem with these is that if you bolt them on, or if you attach them to the top of the thief hatch, you can't use the thief hatch to just look down into the sand mover. So you have to develop other ways to monitor what's going on. But these markedly reduce the exposures. You can see the dust where the control is not in place on the left, and you can see how much clearer things are on the right. Next slide. And in fact, in studies that were done to look at the effectiveness of having the engineering control in place, you can see the two graphs at the top are respirable dust concentrations with the control off or the control on. And at the bottom two graphs are respirable, the bottom two graphs are respirable crystalline silica with the control off and the control on. And you can see that at the stations, if you're unlucky enough to work at one of the stations where there are these thief hatches, if you have the control on, your exposure is much less, both to respirable dust above and respirable crystalline silica below if the control is on. Next slide. So OSHA's OSHA has a respirable crystalline silica rule for general industry and maritime that was put into place, I believe in 2014 was when it was promulgated. And the standard requires employers to do a variety of things that are listed here. I'm not going to read everything to you, but basically the permissible exposure limit is 50 micrograms per meter cubed, and there's an action level at 25 micrograms per meter cubed. And so basically, if employees have exposures above that action level, a variety of things are required. And in addition, people have to be kept below the PEL. You have to limit access, use dust controls, provide respirators, use housekeeping methods, have written exposure prevention plans. And we'll talk a little bit in detail about medical surveillance that must be offered to employees who have exposures above that action limit of 25 micrograms per meter cubed for 30 or more days per year. You have to train workers and keep records. Next slide. Next slide, please. Okay, thank you. So in terms specifically of hydraulic fracturing of unconventional natural gas production, general industry and maritime employers must comply with all requirements of the standard by June 23, 2018. So it's mostly in place, except for the following. Medical surveillance must be offered to employees who will be exposed at or above the action level for 30 or more days a year, starting on June 23rd, 2020. Okay, so starting June 23rd, 2020 is when we have to start, is when employees who have that exposure have to be offered periodic surveillance. Currently, periodic surveillance has to be offered for those who are above the PEL. So when the regulation was first phased in, people had to have surveillance if their exposures were above 50 micrograms per meter cubed for 30 or more days a year. And as of June 23rd, 2020, workers will have to be offered surveillance if they're above 25 micrograms per meter cubed for 30 or more days a year. And then hydraulic fracturing operations in the oil and gas industry must implement engineering controls to limit exposure to the new PEL by June 23rd, 2021. So hydraulic fracturing operations got a bit of a pass. Other parts of industry had to be controlling exposures in 2018, and hydraulic fracturing was given until 2021. Next slide. So here's the medical surveillance that needs to be offered. Again, it has to be made available within 30 days after initial assignment. Periodic examinations at least every 3 years. It includes a medical and work history and physical examination, a chest x-ray interpreted and classified using the International Labor Office system by a non-certified V-reader. That's a standardized way to look at an x-ray and grade the presence and severity of dust-induced changes. Spirometry has to be provided, administered by a technician with a current certificate from a NIOSH-approved spirometry course. At initial examination, the worker has to be tested for latent tuberculosis. That can either be done with a skin test or an interferon gamma release assay. And any other test deemed appropriate by the physician should be provided. Next slide. In terms of reports, the regulation was set up to protect the confidentiality of the worker. So in terms of medical report for the employee, the results have to be explained in a written report provided within 30 days of each medical examination. And the report has to include results of exam, recommended limitations on use of respirators or exposure to respirable crystalline silica, and a statement that the patient should be seen by a specialist if the chest x-ray is classified. This 1-0 is the lowest level that's compatible, that's consistent with pneumoconiosis. In terms of medical report for the employer, that's different, and you'll see it protects the worker's confidentiality. The report has to be provided within 30 days. It has to include the date of the exam, the statement that the exam met the requirements of the regulation, and recommended limitations on use of respirators. Then only if the employee provides written authorization. A written opinion also includes recommended limitations on exposure to respirable crystalline silica and a statement if the employee should be seen by a specialist. But that's only if the employee provides written authorization. Next slide. Okay, so I guess if we're doing questions during the talk, I'll stop at this point and see if there are any questions up to this point. And if not, I'll go on and I'll talk a little bit about asthma exacerbations. Next slide.
Hi, I have a quick question. Do you have a sense of how many workers are out there that would be affected by these rules?
Well, for silica, I can't give you the exact number that are in the hydraulic fracturing industry. For silica, there's publications that there are, probably about 2 million workers that are exposed, because that includes construction, and general industry. And then in terms of those who are exposed above the bell, I can't give you any. I'm trying to remember what the numbers is. I think that's on the order of like tens of thousands. That's on the order of tens of thousands across the country that would be expected to be exposed above the bell. But I can provide a reference afterwards.
Okay, thanks.
Give that to Caitlin. Any other questions? Okay. So this slide shows in the left-hand panel various exposures that are associated with unconventional natural gas production. Again, you have the diesel, so you have NOx and VOCs and particulate matter. You have air toxics, because you can have the same kind of reactions in the air as with air pollution. So you can have ozone in the air. So you can have a variety of things in the air that are known to be problematic for asthmatics. And on the right-hand panel, you can see a table that comes from a paper that was done by the Geisinger Clinic. And what they looked at was in Pennsylvania, in the area where the Geisinger Clinic was. They looked at the far left-hand column at exposures at these various stages of unconventional natural gas production. So when they're building the pad, when they're drilling, when they're doing the stimulation, that is when they're putting the fluid down, when they're doing the production, when they're sucking the natural gas out. And they rated those exposures and people living in the vicinities of those operations as low, medium, or high. And then what they did is in the three columns that you see to the right, they looked at the odds ratios for adverse asthma outcomes, including asthma hospitalizations in the first column, asthma ER department visits in the second column, and oral corticosteroid orders in the third column. And as you can see, as you look down these, as you have increased levels of exposure to these various levels, to these various stages of unconventional natural gas production, you can see that there were increased risk of these adverse asthma outcomes in the communities, among people that live in the vicinities of these operations. So this is kind of preliminary data that suggests that living near these operations can be an issue for people with asthma and can trigger adverse asthma outcomes. There hasn't been much literature on this yet, so this is suggestive, but it is an early indication that there may be concerns, and definitely additional work needs to be done to see if this can be verified in other sites too. Next slide. Okay, so now I'll talk a little bit about hydrocarbon gases and asphyxiation risk. Next slide. And So an additional inhalational kind of issue that's come up with unconventional natural gas production is the concern of asphyxiation due to low oxygen environments related to checking the tanks that either include product or include the waste gas water. And you can see on the left-hand side a worker, again, at a thief hatch where he's manually gauging a tank. So he's got that pole in his hand and he sticks it through like a hole at the top of the tank, and that's how they check to see how much fluid is in the tank. But unfortunately, if you look on the right-hand side, that's that's an infrared picture of hydrocarbon plume that comes out of a thief hatch when you open it. So what happens in these tanks is you have volatiles in the tanks, and when they're closed and sitting out in the sun, you can develop considerable pressure from the gas phase that's above the liquid that's in the tank. And when you open the thief hatch, you get this plume, and if somebody's standing within the plume, they can be overcome because there's, from asphyxiation, because there's low oxygen in that area. Next slide. So these are measures that were taken, hydrocarbon gas and vapor concentration measured about 1 foot above an open production tank. And you can see the concentrations that were measured when these hatches were open in the first column. Actually, the first column is the type of gas or vapor. The second column is the concentration. The third column you can see is the IDLH. That's the level that's immediately dangerous to life or health. And you can see those IDLH values are much lower than the concentrations that were measured. So you can imagine that this is a potential problem. Next slide. And in fact, it really is. So this is a table that shows fatal asphyxiation events that occurred from 2010 to 2014 among workers that were exposed to these these conditions when they gauged or collected samples. And I won't read this to you, but basically these folks either opened up hatches or got above these tanks and were asphyxiated and died. Next slide. And so NIOSH and OSHA put out recommendations for manual tank gauging and fluid sample collection to try to reduce these mortalities. And I put in yellow the most important thing, which is it'd be best to have alternate tank gauging and sampling procedures that enable workers to monitor tank fluid levels and take samples without opening the tank hatch, because that takes care of the core issue. If you can't do that, if for some reason that's not practical, there are other measures that can be taken. And I'm not going to read this to you, but the bottom line here is prevention. Next slide. So I've got some references here for the things that I talked about in the talk. Next slide. So that finishes up what I had to say, and if there are any questions, I'll try to answer them.
Thank you, Dr. Weissman. That was wonderful. I know Dr. Doyle had to step out to see some patients, but he chatted me that he really liked the didactic. He's going to finish watching it, and he was happy for how many people showed up to see this.
And I saw he had his face mask on, so COVID-19, there we go.
Yeah. So if anybody has questions, you're welcome to unmute yourself or chat in, and I'll read them. You can also email me later, and I'll make sure Dr. Weissman gets those if you have a follow-up question that you can't think of right yet.
So
this is Sam Giordano. I may have missed it, but what personal protection equipment besides flame retardant clothing should these people be wearing in order to avoid inhalation of those gases?
So really kind of the best So you're talking about the asphyxiation at the end?
Yes.
So really the best thing is to avoid creating the environment where people are put at hazard. So the best thing is to use engineering controls that you don't have to open up those hatches. If people, it's not part of the recommendation, but if people were going to be exposed to these low oxygen environments, and you were to do respiratory protection for that, you would really need to use some sort of supplied air, or some sort of respirator that supplied adequate oxygen, because it's an asphyxiant risk. I mean, that's not one of the recommendations, because if you have to it's much better to fix the environment than to depend on that type of equipment. But for a low oxygen environment, it would just be like a enclosed space kind of thing. You would have to have something that supplied a breathable atmosphere that included enough oxygen.
Yeah, like what we see firemen wear.
Exactly. But you don't want to have to rely on that, because because if something goes wrong with that, then the worker's in trouble. Better to prevent the situation altogether.
Absolutely. Thank you.
Hi, this is Eric. I have a question about the medical surveillance. So
Sure.
does that imply that when that requirement, or maybe it's already started, does that imply that there would be a flow of workers in these industries to clinics or hospitals, or to get that screening, those physical exams, or where does that service happen, or
Yeah.
who can provide that service?
Yeah, I mean, the responsibility is for the employer to pay for it, okay? And the employer needs to contract with a provider to provide those services, with a clinic or an occupational health provider, or a clinic that can provide that testing. And you had asked earlier, I think, about the number of people that were involved, and I believe OSHA estimated that this was going to trigger across the country, probably, over the first couple of years, like about 150,000, people needing to be tested. So it will be a substantial, pulse of people needing, testing. Does that answer your question?
Yes. And I also wonder if any of our, hospitals and clinics on the call, are they seeing these patients yet? Are they starting to flow to them, or is this still to come? Or do they not expect to see these patients?
I know we've had people reaching out to us from various clinics, looking for, certified B readers to look at the x-rays, or wanting to send spirometry technicians to take NASH courses. But I'll defer to the others on the call to see if any of the clinics are seeing business related to the silica rule. Can anybody answer the question, or are you seeing more patients because of that? Well, we're kind of hearing silence here, right now, but like I say, it was supposed to start in 2018, and for hydraulic, and the surveillance requirements for hydraulic fracturing also started in 2018. And the number of covered employees is going to increase this year, because instead of needing surveillance only if you're above the PEL, the line is going to be half that. It'll be the action level starting in June 2020. So people should be seeing, if you're contracting, with covered industry, construction industry, you should be seeing cases.
We had a chat come in that that Lincoln County hasn't quite seen these patients yet. But
yeah, and again, it's there are requirements both for construction and general industry and maritime, So it should be everywhere in the country because there's construction and general industry everywhere.
Right. Absolutely. Again, we thank you so much, Dr. Weissman. Any other questions, comments? Marvelous. Again, let me know. You guys can email me if you have any follow-up questions. I'll be posting this to the Project Echo YouTube, so you guys can review it again if you'd like to. So we do have a little bit of time left. I've had a couple of emails about, of course, this thing that nobody can stop talking about. So I was going to open it up to all of you guys to kind of discuss. We've had people wondering if they should close their pulmonary rehab programs. We've had people wondering how everybody's going to be handling this, in private clinics or, just rural. So I don't have any answers, but I thought maybe you guys could talk if somebody wants to throw out the first question.
This is Sam Giordano. I'll get my feet wet. I understand from my contacts that several pulmonary rehabilitation programs are temporarily closing just because they don't want to cluster at-risk patients together, especially if they haven't been tested. And what can we do as a group to follow these patients or guide these patients as they self-isolate during the pandemic? Oh, and also, since chronic pulmonary disease patients are one of the top at-risk groups, what can we do and advise our patients to avoid emergency department visits, physician office visits, and hospital admissions?
Has anybody's clinic done changes? So Dr. Doyle hopped off the call, but he was talking about how the reason he's hopped off the call is because their clinic starts at 9 a.m. and they're meeting all the people outside to screen before they come in. Let's see, some people are closing until further notice. Yep. Anything else that people are kind of trying to enact or keep going? I know our office is going to close here. We're all just going to start working from home. They didn't let us know until 10 o'clock last night.
No, I think. Go on, I'm sorry.
Sorry. This is Tara from Preston Memorial Hospital in Kingwood, West Virginia. I left work on Thursday last week, and we had discussed closing pulmonary rehab, which I'm sure that that's going to take effect this week.
Yeah.
We have a hotline set up through Mon Health for our patients to call if they have questions about what's going on. But we've also been informed about what to say to them.
So are you guys going to close until further notice as well, and kind of just give them some tools to use on their own?
That's my understanding. I go back tomorrow, but I'm sure that that's, I left Thursday and things were still in, a preliminary decision-making process, but I'm sure that's what we'll be told tomorrow, to call everybody, tell them to stay home, and we'll let them know when to come back.
Yeah, absolutely.
Are you giving them any instructions while they're staying home, do's and don'ts, or any ways they can continue at least with a segment of your pulmonary rehab program at home?
That's what we'll discuss tomorrow, I'm sure, because that's what my question is. Like, I would be happy calling them and instructing them on what to do on Tuesdays and Thursdays. But again, I guess I won't know until tomorrow when we all sit down and talk about how to proceed.
Right. Are more people gonna try, I don't know, obviously, but maybe try a video, like a Skype back and forth with people? Dr. Doyle's back. Dr. Doyle, would you like to talk?
Yeah, I missed what some of the people were saying. I see some of the chats. I just heard Tara talking about Preston and see Johnny and Brandy's comments. So I just broke away for a few minutes to go outside because today's a pulmonary rehab day for us. And we have a really good class right now. We have 10 people, several with pretty severe complicated pneumoconiosis, PMF, several who aren't that bad at all. And so of our 10 this morning, and so what we decided for the first time today is to screen everybody literally outside the door before they came in with a set of screening questions, not taking their temperature, just looking at them, talking to them, and screening questions. So of 10 people, 1 called in, 2 we sent home, 1 because, and both of them were kind of runny nose and head congestion, nothing else, and 7 cleared and are down there starting right now. We have not, and all of our pulmonary rehab, all 4 of our pulmonary rehab staff are here. Some of you know them: Brenda, Marion, Lisa, Emery, Susie, Chris, Tony Canada, and so 5, I. So we're all here. We're all well so far. And the decision about whether, the risk benefit to them of coming or not coming is a really close call, and we'll decide it day by day.
Does anybody have any other questions or comments? Or I know there were several things. Insight. I work with Dr. Hodder here in the CTSI, and she comes in every day with a new update or something.
I think one of the good things that we do as pulmonary rehab is that we're always reinforcing what you're going to be doing after the program anyway. And so that kind of helps the patient kind of get in their routine. If they're missing that day, or if some reason pulmonary rehab's not going on that day, then they continue their pulmonary rehab at home anyway. So I think that is one of the good benefits of the pulmonary rehab, that we always plan in for that situation when they're not here anyway. And so they just kind of encourage them to follow that protocol, at home.
I think that's a wonderful point, really encouraging them to be independent and, take some matters into their own hands when they can't get good. I understand.
Oh, that helps me a lot, because I was thinking a lot about, what are the special messages to tell these patients at this point. But basically, if you've got a PR program in place already, you're already armed with all that information for how to lead their life after PR is done. And you can just, they can get an early start on some of that. And you have the handouts and the resources available, and they can start now. And if you're not seeing the patients in your building, you still can, you can switch your time to calling them or doing some outreach and ask how they're doing and encourage them to do whatever they need to do. So you don't have to invent a lot of new intervention. You just sort of rearrange when it gets to them, maybe.
Yeah. Even every time they graduate their Dynabands, we give them one to take home so that they can continue. So you're all the time kind of reinforcing that.
Yeah.
This is Brandy at Southern West Virginia Health Systems. I will say we have a Facebook that a lot of our patients see regularly in the world of social media. And we have recently, in the last week, posted a lot of, credible links, education about just, washing your hands, avoiding public, sanitizing, surfaces, just different things like that. And I think a lot of our employees are sharing that. That way it reaches a lot of our community. Just some good, solid education we've been doing. And again, like Johnny said, We have closed our pulmonary rehab for now, and we're just going to kind of reevaluate, kind of like the school systems. But I did reach out to all 8 of my patients, and as you guys can imagine, every conversation lasted about 15 minutes with each of these patients, just educating and reassuring and just, you know, giving them some education about what I advise and our pulmonologist would advise them. You know, just try to stay home, wash your hands, send someone else out to the grocery store if that's something you have available to you.
Brandy, this is Dan. Something I would like to comment. You know, we've talked a lot over the years about the fact that Medicare now pays for chronic care management, and that's billable. But I don't know if, and I've always felt like respiratory therapists could and should be doing that with our COPD patients, especially our post-PR patients. But it's been a very slow uptake. And I just want to say that those visits that those 15-minute visits that you did with those patients, you have to do 20 minutes in a month to bill for a chronic care management visit with Medicare. But what you were doing there is exactly what chronic care management and disease management consists of. And I would encourage everybody to think about billing for that. And whether you bill for it or not, that you are doing it is crucial, because we have a cohort of high-risk COPD patients.
That's very true. Thank you. I know I spent a lot of time with them on Friday.
This is Sam Giordano again. I hate to comment so often, but since there is a national emergency been declared, I believe that the Secretary of HHS and the CMS administrator now have authority to waive certain rules and regulations. And I have a meeting, a conference call scheduled with my executive committee of the coalition to discuss recommendations for suspension of the restrictive rules, if you will, that respiratory therapists have to undergo. And by that I mean to allow clinical visits for the homebound, which we are not reimbursed for, but I don't see any harm in asking for the duration of the pandemic that this be done. And I also believe that since COPD patients tend to exacerbate most at least once a year, we could work upstream and lessen the stress and on the healthcare system, especially our hospitals, emergency departments, and physician offices. We will also consider asking that registered respiratory therapists be allowed to become Part B providers and therefore employed in physician practices without direct supervision. This means they would be allowed to make home visits if deemed medically necessary, but it would free up, I think, therapists to intervene at distance. You mentioned, Brandy, your telephone. I think if we're going to be, temporarily closing pulmonary rehab programs, that all programs, and it's easy to give advice, harder to take it, have a script or checklist where they would call. Those calls you made are fantastic, but can they be made on a regular basis, such as weekly? How you doing? Because not only do we have to worry about COVID-19, we have to worry about just the regular, typical exacerbations that these patients undergo that trigger an increased demand on the healthcare system. Here endeth the sermon.
Well, thank you all. Anything else everybody needs to discuss?
This is Dan. Has anybody yet talked about West Virginia, the illusion that West Virginia has no cases?
We haven't talked, well, I mean, I've talked about it internally up here. We have not talked about it as a CLD group.
Well, certainly Dr.
The
Martin.
illusion?
Yeah, so West Virginia isn't doing amazing testing for it. So it looks like there are no cases, but they've only tested about 20 people. So, yes.
So the point is that realistically, that probably almost certainly is an illusion. And so that even though there are no cases, I think all of us, I see Johnny shaking his head, and Brandy, and Dean, all of us know that we need to be taking the same precautions that everybody else is. And if it turns out that we have a little bit of lead time, so much the better. But definitely, and so with that respect, protecting our workforce is really, really crucial. And so trying to get everybody to learn to use proper protective equipment, trying to reduce unnecessary oropharyngeal and nasopharyngeal swabs, which are aerosol generating procedures that put our nurses and MAs at risk if they're collecting those specimens, and only collecting them with proper precautions, all those things. And then especially in our classes with our patients, really helping them more than ever to learn about how to protect themselves. And all the stuff that we already know about, but just reinforcing it for them and making sure we're modeling it for them ourselves, just as much as if we were in New York City or San Francisco or wherever. We're not immune.
Well, that's really interesting. I was wondering from this distance, what's the explanation for the case counts in West Virginia? Thinking, well, it's like one of the times when it's lucky West Virginia is last in the stats, but now I understand a little better.
It's lack of testing.
Right.
All right, guys. Anything else? I don't want to cut you off. Certainly, we have about 2 minutes. But all good. So let's see. Our next meeting is April 6th. Dr. Sila is actually going to take both of the April sessions. She presented for us, I think, the first session of the year about the NICE guidelines, and there was some really good information, and everybody was very interested in it. I can send out that past session's YouTube link so you guys can kind of do the refresher. She's going to circle back around to that to answer some of the questions we got afterward and to continue some of the discussion on that. And then she is also going to talk about some of the pulmonary rehab updates, of course, which might change with all of this information and everything, but we will see. But just so you all know. Everybody have a wonderful day, wonderful week.
Thank you, Caitlin. Thank you, Dr. Weissman. That was great.
Thank you.
Thank you.